Ladies and gentlemen, with that, we conclude Symposium 18. And now we'll commence Symposium 20, focusing on endocrinology, adrenal, and thyroid. With this, we'll discuss about challenges in primary hyperaldosteronism, surgical management of well-differentiated thyroid cancer, and thyrotoxicosis. It's my pleasure to invite the chairpersons, Vidya Jyoti, Professor Seneviratne, and Dr. Shalika Ariyawansa.
Good afternoon, everyone, and I warmly welcome you to this session on endocrine disorders, thyroid, and adrenal. Our first speaker for the session is Major Dr. Ricardo Rafael Correa Marquez. He's a physician scientist, educator, leader in endocrinology, medical education, and health equity, and he serves as program director of endocrinology, diabetes, and metabolism fellowship and director of health equity and inclusive initiatives at Cleveland Clinic's Endocrinology and Metabolism Institute. There's a long CV. For interest of time, I'll just skip the rest. He's going to talk about challenge of primary hyperaldosteronism. So he's going to be joining us virtually.
Hello, everybody. Again, I want to thank the organizing committee for the amazing invitation. I really appreciate it, and I want to express my excuse again for some personal and issues couldn't go there. But as I mentioned yesterday, I'm here for any questions, try to answer it. I'm trying to go over this topic that is so important, that is the most common condition of endocrinopathy hypertension, that is primary hyperaldosteronism. Thank you so much. Thank you for attending the lecture. Thank you to the organizing committee. And I hope that you're enjoying this amazing conference. There is no conflict of interest for this lecture. There are some things that I'm doing, and I participate in the guideline for the primary hyperaldosteronism update from the Endocrine Society. So let's start talking a little bit of hypertension. As we know, it's the most common reason that a visit for in general internal medicine doctor gets, and it's the most common disease that is prescribed. Most cases of hypertension you usually present in older age, but if it's present in younger age, we should suspect about secondary causes of hypertension, and patients that has been treated with 3 drugs, including one of the diuretic, that have resistant hypertension, we should start suspecting secondary causes of hypertension. The diagnosis of hypertension is becoming more and more common. Resistant hypertension also is being diagnosed more common. But even though resistant hypertension is being diagnosed more common, the real clear cause of the resistant hypertension is not yet diagnosed. These are suggestive features of secondary hypertension, resistant or severe hypertension, an acute rise or increased liability of blood pressure, malignant hypertension, hypertension associated with spontaneous hypokalemia, hypertension that present less than 40 years old, and if the age of presentation of hypertension is in puberty. The accurate diagnosis of secondary causes of hypertension make us a better treatment and make us probably cure the patient in a better way. There's multiple causes of secondary hypertension. I will focus on the endocrine causes and mainly on the primary hyperaldosteronism, but we know that pheochromocytoma paraganglioma syndrome, that excess of cortisol, that congenital renal hyperplasia, the acromegaly, hyperthyroidism, and hyperparathyroidism can cause hypertension, but the most common cause of endocrine hypertension is primary hyperaldo, and this is the focus of this lecture. So let's start talking about aldosterone. Aldosterone is a hormone produced for the zona glomerulosa on the cortex of the adrenal gland. It's the most important mineral corticoid, but we know that glucocorticoid at higher doses can stimulate the mineralocorticoid receptor. It's not regulated by the pituitary gland, it's regulated by the renin-angiotensin-aldosterone system, and renin being secreted in the kidney. It causes sodium excess and volume expansion. Also, it causes some potassium deficiency. If we look on the right side, we can see that there is a histological cut of an adrenal gland. In the center, you will see the medulla, and we see the three cortex layer, the glomerulosa, the fasciculata, and reticularis. In the past, we used to learn that each of these three layers are very separate, but really we know now that the zona glomerulosa and fasciculata overlap each other. So every time that we have a patient that we are suspecting of primary hyperaldo, we should look for cortisol excess. And every time that we have a cortisol excess, we should look for aldosterone excess. So it is because really those two zones are not differentiated. The reticular is the biggest zone and is very differentiated from the other, but the first two are not. So what we are looking is really the extreme left, a low renin, high aldo setting. This is primary hyperaldosteronism. When we have a high renin and a high aldo, this can be other things. This can be renal artery stenosis, this can be Bartter or Edirimanne syndrome. And if we have a low renin with low aldo, this is also not primary hyperaldo. This is an apparent mineralocorticoid excess. This can be in use of liquorage. Usually in the US, we don't use a lot of liquorage, but in Europe, they have a lot of liquorage that can cause this setting. But also, for example, a patient that have congenital renal hyperplasia or Little syndrome or other syndromes. So really, we're focusing in this lecture the condition called primary hyperaldo, where we're looking to a low renin hypertension and low renin hypertension with elevated aldosterone. The prevalence of primary hyperaldosteronism has grown up in the last year, probably because we are detecting more. Up to 10 to 30% of patients with hypertension can have primary hyperaldosteronism. And we can say that up to 40 to 50% of the patients with resistant hypertension most likely have primary hyperaldosteronism. It increases if the hypertension is associated with spontaneous hypokalemia, but patients even normotensive can have primary hyperaldo up to 10%. So it's a broad spectrum of ranges that is very important to make the diagnosis. And why? Because aldosterone is not only a blood pressure hormone. It's a hormone that affects and has receptors in many parts of the body. We know one, we know the remodeling of the heart. And that's why we block with spironolactone in your heart classification 3 and 4. So really, it's an effect on multiple organs, and we will talk about some of them, that is important to make diagnosis and then the treatment correctly. Most likely is detected between the 3rd and 6th decade. Patients usually that has hypertension with primary hyperaldo compared with hypertension non-primary hyperaldo has higher risk of stroke, MI, coronary artery disease, arrhythmias. So independent of the blood pressure. So even though we have been trying to talk about making the diagnosis of primary hyperaldo, still 2% of the patients with hypertension are screened only for primary hyperaldo. So it's extremely important, and new guideline just published 2 months ago reassure that every patient with hypertension and more, every patient with resistant hypertension should be screened for primary hyperaldosteronism. So this is at least like the prevalence. We can see that normotensive persons have up to 11% chance of getting primary hyperaldo, but when we get to stage 1, stage 2, and resistant stage 3 hypertension, up to 50% of the patients can have primary hyperaldo. So the prevalence increase, and that's why it's important to make the detection. And why primary hyperaldo is underdiagnosed is because we don't look for it. And we don't look for it, and if we look for it, we often misinterpret the results. What is the most common cause of primary hyperaldo is bilateral hyperplasia. The second most common cause in aldosteronoma and it's in our lecture yesterday, you will see there's a fatty rich tissue that you can find. But the most common is not that aldosteronoma. The most common is bilateral adrenal hyperplasia. There are rare causes, and I will not focus on this. There are familial causes, like glucocorticoid-mediated hyperaldosteronism type 1, that is really direct because there is a lack in the gene and there's direct for ACTH. But those are more rare conditions, and really this is not the focus of the topic of the lecture. And this is very important to understand because the vast majority of primary hyperaldosteronism is attributable to diffuse and bilateral foci that is producing aldosterone. So what happened is that at the beginning you see a normal adrenal glands. These adrenal glands start progressing, losing some somatic mutations, and start developing some foci that produce excess of aldosterone. These foci that produce excess of aldosterone start growing up and producing more aldosterone, and this is the most common disease. Sometimes the one of those start growing more with more mutations and then create a growth, a nodule, that is the aldosteronoma. But that's not the most common. The most common is the prior one, where you can see a lot of red dots in the adrenal glands. There's multiple secretions across that. And sometimes when you have an aldosteronoma in one side, it doesn't mean that the other side has not the somatic mutation that is being produced and can cause an excess of cortisol, of aldosterone. And here I put a list of some of the somatic mutations that has been discovered in patients that have primary hyperaldosteronism. These are the mutations and the channels where they work. So every day we're discovering new and new. So as you can see, there's multiple mutations and multiple channels affected. Even though the potassium channel is the most common one, there's other channels that are affected that can cause this overproduction of aldosterone. So if you think about, nearly all PAs are caused by pathogenic somatic mutations that results in those foci that start producing aldosterone. Those foci generally arise diffusely, bilateral, do not have one prevalence of one or another, and with time it can accumulate, and with time also can grow into one of them becoming an aldosteronoma. The absence of an adrenal nodule do not exclude the possibility of primary hyperaldo. And always, because of the relationship between the glomerulosa and the fasciculata, we have to look for co-secretion between aldosterone and cortisol. So what are the clinical features? Is a person young, between 20 and 60 years old, with hypertension. Any kind of hypertension is, as I told you, even normotensive patients, but more the resistant hypertension. They can have 1/3 of them spontaneous hypokalemia. Not having spontaneous hypokalemia do not rule out primary hyperaldo. So you don't have to find spontaneous of hypokalemia to make the diagnosis. The really diagnosis is a patient with hypertension. There are unique characteristics. If a patient is young, they say less than 35, I say less than 40 years old, with spontaneous hypokalemia, with high blood pressure, and an adrenal incidentaloma. Those are very straightforward, and you can remove that aldosteronoma, and that's the cause. But it's in those very specific younger population with spontaneous hypokalemia and elevated blood pressure. There is other mutations, most common the Kisain gene 5 mutation that is more prevalent in female and Asian population. And there's other more common in men's, the ATP1A1 and 2B3 in men's. So do all patients with primary hyperaldosteronism have hypokalemia? And the answer is no. As you can see in this cohort, only 7.8% were found to have spontaneous hypokalemia. So many times we miss the diagnosis because the patient do not have spontaneous hypokalemia, but that's not making the diagnosis correctly. So to recap this first part, primary hyperaldo is in an appropriate production of aldosterone in a non-suppressible renin-angiotensin aldosterone system. So the renin is not being suppressed, and the aldosterone continue to be produced in high concentrations. The excessive activation of the mineralocorticoid receptor, the expansion of volume, the hypertension, cardiovascular disease, and kidney disease are more frequent in patients with primary hyperaldo and are independent of the blood pressure. So aldosterone is a hormone that is affecting it. What is the hallmark is the suppressed renin, a low renin hypertension with excess of aldosterone. And the clinical manifestation do not to have hypokalemia, is high blood pressure, more in resistant hypertension, but also normotensive patients can have. So who should we screen? We should screen at this point. This was the prior recommendation. The new recommendation is every patient with hypertension should be screened with renin-aldosterone ratio. Every patient with hypertension. Of course, the patients with resistant hypertension should be screened faster. The patient that has spontaneous hypokalemia should be screened faster. The patient that have adrenal incidentalomas and hypertension should be screened faster. Or the patient that present younger in life or with family history of hypertension in their younger life of their family should be screened faster. But in general and overall, every patient with hypertension should be screened for primary hyperaldosteronism because of the higher prevalence of the disease. How do we make the diagnosis? It's get a little bit more complicated, but the best thing to do is let's detect the renin and aldosterone in the patient. So all patients, as I mentioned, with hypertension should be screening. And what we are looking is the plasma aldosterone concentration and the plasma renin activity or plasma renin concentration, depending on what your labs give you. If the plasma renin activity is less than 1 or suppressed, or the plasma renin concentration is lower than the lower limit of normal, suppress. That's low renin. If the patient has hypertension, it's low renin hypertension, high risk of primary hyperaldo. And then we look at the aldosterone and we see that the aldosterone is more than 10 or 277 picomoles per liter. Then we make the diagnosis of primary hyperaldosteronism. So it's in the past we used to use confirmatory testing, and I will mention this, but really a low renin high aldo hypertension is primary hyperaldosteronism in some kind of way. If you want to measure the ratio, a ratio more than 30 has a sensitivity and specificity of more than 90%. So if you do the ratio, you will see. But it's important that whenever you do the ratio, you understand that this is a low renin, because sometimes you can have high renin and high aldo, and that can give you a high ratio, but that most likely is a reninoma. If you have a low renin with high ratio, then most likely is primary hyperaldosteronism. In the past, we used to call this confirmatory testing, and not anymore because we are not confirming anything. Really, with the diagnosis of low renin hypertension with elevated aldosterone, we make the diagnosis of primary hyperaldosteronism. We can do some aldosterone suppression tests in cases, and this is more for endocrinologists that we do to determine how severe is the disease. And these are the oral salt loading, the saline suppression test, and others. The most common that we use in our clinic is the saline suppression test, where we give 2 liters over 4 hours of normal saline. We measure the potassium before, we measure the aldosterone after, and we expect that the aldosterone suppress less than 5. If it's more than 10, we make the diagnosis. If between 5 and 10 is indeterminate. It depends. There's some other prefer, because they don't have that in the clinic, I prefer the oral salt loading. It's at 3 days, where you have to give a lot of salt to the patients. There is the fluorocortisone and the captropil challenging test. But really, it's a more a referral at this point, not a diagnosis. The diagnosis is with the tests that in the past we used to use screening tests, but we can confirm with those screening tests. There is special consideration. Again, I want to mention a patient younger age, less than 40 years old, with spontaneous hypokalemia, hypertension, and aldosteronoma, and an adrenal incidentaloma with a high ratio. Definitely that you don't need to do anything else. You just go and remove that. So a positive confirmatory test can affirm your clinical suspicion, but a negative confirmatory test do not reliable to exclude primary hyperaldosteronism. That's why we decided not to use more confirmatory testing and you use aldosterone suppressant test. Really, that first step is the key to determine if the patient have or not primary hyperaldosteronism. So the next step after we determine that the patient have primary hyperaldosteronism is to the subtype. This is a most common bilateral hyperplasia or double bilateral foci, or this is a one-side adenoma that is producing. We can do this. One is the first thing is to do a CT and see if there is nodules. But the CT will not always give us the correct answer because sometimes there can be a nodule, but the other side is the foci that are producing. Then we go to the next step, that is an adrenal venous sampling. An adrenal venous sampling is a process that I will explain in the next slide. So we move from calling a unilateral to bilateral disease to lateralizing, meaning that it's in one side, lateralizing, and non-lateralizing disease, meaning it's in both sides. This is an CT images where you can see that in the first one is a 1.5 centimeter right adrenal incidentaloma, fatty, lipid rich, so the insulin is low. Meanwhile, in the second, you see a bilateral hyperplasia. So here you can see a lateralizing versus a non-lateralizing disease. And as I was mentioning, we have the image in the CT, but besides the CT, we need to refer this patient to a center that can do an adrenal venous sampling. An adrenal venous sampling is the measurement of aldosterone in each one of the adrenal glands and determine if they have both producing or one is producing more than the other or just one is producing. And it's a process that interventional radiology perform. We, between endocrinology and interventional radiology, we get some ratios, and that ratios will determine if this is a non-lateralizing disease or a lateralizing disease. And why is it important? Because lateralizing disease, the treatment of choice is removal of that nodule, and non-lateralizing disease, the treatment of choice is medical treatment. It's minimal complications. The only thing is that should be done by a skilled interventional radiologist because the right adrenal gland, as you can see, go directly from the IVC, and then that is difficult sometimes to cannulate. So we do some calculations with cortisol to see if the cannulation is correct, and then to selectivity index we call to see if it's in non-lateralizing or lateralizing. So there are new tests that are upcoming, and I just want to mention these two slides about this. There is nuclear medicine, so that in the future, most likely we don't have to perform AVS, invasive procedure. We will be able just with nuclear medicine and this component, CXCR4, we will determine if the is lateralizing or is both sides or one side producing. Here is some of those examples from the study that was published in the recent years, and you can see sometimes how this can be determined in comparison with ABS. So to summarize this part is really the first thing is we have a positive, what we used to call screen test, a low renin, high aldo, hypertension. Then after that, we don't have to go to confirmatory test, but in some cases, we will do this aldosterone suppression test. Then we will perform, if the patient wants to be surgical, we can do the further test in the CT and the ABS. If the patient is not a surgical candidate, we should start the patient immediately in medication. Also, if you are in an area that you don't have access to the next steps, the CT or an IVS, you can immediately start medication therapy in those patients. If you have access to that and the patient is a surgical candidate, then we will do the lateralizing techniques to see if the patient can have, when we do the CT scan, if we find a nodule and then the AVS and we find that goes to one side, then it's lateralizing disease and is surgery the treatment. If not, it's bilateral, so it's non-lateralizing disease and then it's medical treatment. So these are the treatments that we have. We talk about surgery. Aldosteronomas are removed, and those are the best data that we have for curing a primary hyperaldo. But we have medical treatment in case of non-lateralizing disease. We have mineralocorticoid receptor antagonists like spironolactone. In spironolactone, we can go up to 600 milligrams per day. Sometimes I know that when we hear 600 milligrams per day, spironolactone is a lot, but yes, we can go up that. What we are looking is in this renin that is suppressed, make it non-suppressed renin. Eplerenone is another one with less side effects in other organs, but with less potency than spironolactone. We can have a second-line therapy in triamterene and amiloride on top of the first line. We have some new medication, finerenone, as you are aware, for CKD. It's in patients with diabetes, has been a lot of option, but the subset is just a very small group that were done in treatment of primary hyperaldo. That's why it's not yet approved for the management of primary hyperaldo. In Japan, we have exaterenone, and then there's a new study on baxdrostat that is an aldosterone synthase inhibitor with very good results. But those last ones that I mentioned are not approved. Really, we have to start with spironolactone and eplerenone. And if we need to add something, we can add triamterene and amiloride. So if we compare the cardiovascular outcomes in treatment, we know that after adrenalectomy, if this was a lateralizing disease, those are the best outcomes. Then after surgery, if we don't cure, still have a good outcome if we remove the aldosteronoma that was producing the majority of the aldosterone. We have a group that we treat with medication, and we see that the long-term cardiovascular mortality were not so good. But really, if we took that group and we divide the group on being on medical treatment and being on unsuppressed renin, then the cardiovascular outcome improve. So here is not only treat the patient with spironolactone, but is follow the patient with the renin level and make the level unsuppressed. That helps and that improves, and that's a correct treatment. Not just the treatment, but getting that renin unsuppressed. So what is the physiological base approach? So we know that the surgical adrenalectomy is characterized by the reduction of aldosterone and normalization of blood pressure and potassium. There is an increase of the renin, so unsuppressed renin, and this is the reversal of the pathophysiological condition of primary hyperaldo. Medical therapy aspire the same. So we know that we have to titrate that mineralocorticoid receptor antagonist to a way that the renin is unsuppressed, and we can reverse the pathophysiology of primary hyperaldo. Here is some examples on titrating up. So starting between 12.5 to 25, and then also dietary restriction of sodium. We increase the dose, and you can see how the renin become unsuppressed, and that's what we are achieving. So what are the outcomes and this in international consensus of treatment response? Really, we have to be careful with patients when we're trying to up unsuppressed renin. If the patient is having a high sodium diet, we have to correct that first. If the patient is non-adherent, that can be a reason too. There are some medications that can increase renin, like ACE inhibitors and ARBs, and some medication that can decrease renin, like beta blockers, that we have to be aware too. Oral contraceptives decrease renin concentration, not plasma renin activity, and renal impairment can affect renin. So which are the patients that have less response? Patients that have baseline high aldo, baseline very low renin. In an adrenal venous sampling, the selectivity is more than 4 or very low potassium. Better biochemical response are young people, females, shorter duration of hypertension when they don't have organ damage and when they have good renal function. Just a slide of this study published in 2022 of Bactrostat. It's a phase 2 study here. Now we have the phase 3 study, but you can see that the blood pressure improved exponentially in patients that treat with primary hyperaldo treated with this medication. Yet in process, just you can see something in the horizon. What about surgical cure? There is the rule of 1/3. So this means that really 1/3 of the patient will be completely cured, and cure means no blood pressure medication or potassium. 1/3 will be semi-cure because they will be reduced the potassium or no potassium and the blood pressure medication, and 1/3 really will not change. And this is because probably that aldosteronoma was producing aldosterone, but there were the other foci on the other side. There are some predictive factors that for surgical is called PASO. It's lack of family history of hypertension, shorter duration, female sex, 2 or fewer blood pressure medication, and BMI less than 25. Those are all positive for cure. So again, because this is very important, primary hyperaldo and lateralizing is unilateral adrenalectomy, and then evaluate if the patient improved the renin and blood pressure. In non-lateralizing disease, meaning that the patient has foci in both sides, is medical therapy, and then we have to optimize the therapy. We have to control the blood pressure, we have to correct the potassium, and we have to increase the renin, so unsuppressed renin. There are other possible options when we have trying to correct and we're giving spironolactone or eplerenone that increase potassium. We can, if a patient goes to hyperkalemia, we can go and use thiazide diuretics, we can use SGLT2 inhibitors, we can use pathidomir, that is a potassium binder, and we can discontinue any of the lisinopril or ARBs, ACE or ARBs medication. Finally, I want to talk about primary hyperaldo, but the longer consequences of the disease. It's not just the blood pressure. We know that these patients, even what level blood pressure they have consequences cardiovascular and other organs. Let's start first with insulin resistant. We know that patients with primary hyperaldosteronism have more insulin resistant compared with patients with hypertension non-primary hyperaldosteronism. And we know that when we treat it with adrenalectomy, that insulin resistance decrease. We know that there is an improvement in glucose tolerance with treatment. What are the mechanisms? It's clearly unknown, but in one study that we published in 2021, we found that those patients after treatment improve. What is the effect of the aldosterone in the kidney? There is renal vasodilation due to the effect of aldosterone. And if we compare patients with primary hyperaldo and essential hypertension, the primary hyperaldo have increased glomerular filtration, albuminuria, and renal cyst. That's why at the beginning, the GFR of the patient will decrease after surgery, after treatment, and they will go back to normal. In the cardiovascular effects, we know that aldosterone promotes muscle cell growth and hypertrophy, so left ventricular hypertrophy, and collagen deposits, so myocardial fibrosis. We know that there is an increased cardiovascular events in patients with an increase of arrhythmias in patients with primary hyperaldosteronism. In the bone, there is an increase in urinary calcium excretion with aldosterone, so called hypocalcemia. And there is a direct effect on the osteoblast-osteoclast system. So aminorcortical receptor expression demonstrate osteoclast, osteoblast, and osteocytes. So this is also an effect of the bone. In here, you can see that patient with primary hyperaldosteronism has higher PTH compared to the essential hypertension. And this translates to higher calcium in the urine. And when we treat the primary hyperaldosteronism, we know that there is an improvement in the calcium in the urine, so it's decreased calcium in the urine, and an improvement in PTH, lower the PTH. We also know that the bone density improves in patients that are treated with primary hyperaldo compared with non-primary hyperaldo. And they have lower bone density if they have primary hyperaldo compared with essential hypertension. So it takes an average of 17 years from evidence to change practice. So really what we want, and I want to say to all of you today, is that the time is now to change and make the correct early diagnosis of PA so patients can get better treatment and can have better outcomes in longer time. So in summary, primary hyperaldo is not a rare cause of hypertension. It's a very common cause of the resistant hypertension. Primary hyperaldo is common syndrome of low renin hypertension. Every time you see a low renin hypertension, you should suspect of primary hyperaldo. So any type of low renin hypertension probably is a broad spectrum of manifestation of the disease. PA pathophysiology contribute to idiopathic hypertension, but also to cardiovascular, kidney, bone, PTH dysregulation. And pragmatic diagnosis approach can maximize diagnosis, and target treatment for primary hyperaldo will get the patient better outcomes. With this, I open the session to questions. And I want to thank again the organizing committee. I hope that you enjoy the conference, that you enjoy this lecture on primary hyperaldo. There's so many things to talk about, but I want.
So, thank you, Prof. Ricardo Correa, for that excellent lecture. And our next speaker is Professor Senarath Edirimanne. He is currently working as a breast and endocrine surgeon in Sydney. And he'll be talking to us about changing paradigm of surgical management of well-differentiated thyroid cancer. Over to you, Professor Edirimanne.
Thank you very much. It's a privilege and pleasure to be here as a surgeon, to be invited to speak in the CCP conference. I would like to thank Professor Katulanda and the organizing committee for that opportunity. So I was asked to talk about changing paradigm of surgical management of well-differentiated thyroid cancer. But multidisciplinary management is the standard of care in management of cancer patients, including thyroid cancer. So shared management decisions are taken by clinicians, including surgeons, endocrinologists, and nuclear medicine specialists, and the patient. Therefore, I would like to slightly change the topic to change in paradigm of overall management of well-differentiated thyroid cancer rather than surgical management alone. I have a disclosure. While I was preparing for this talk, well-awaited American Thyroid Association Guidelines 2025 was published a few weeks ago. This is a well-awaited because the last guidelines were published in 2015, 10 years ago. So in Australia and New Zealand, we have adopted American Thyroid Association guidelines because we have quite similarities between our populations. And therefore, I'll be referring to ATA guidelines quite extensively during this presentation. We know that over the last, over 3 decades or so, incidence of thyroid cancer has increased exponentially. And this, even though there is a true increased incidence, has been attributed significantly to overdiagnosis. However, this ceased internationally, globally, in 2015, and there is a decrease in incidence of thyroid cancer diagnosis. This could be due to awareness of overdiagnosis, as well as a number of other factors, such as reclassification of some of the entities that were called malignant into benign. The latest data that I was able to find for Sri Lanka, 2021 National Cancer Program statistics. You can see a similar trend. As you can see in females, there is an exponential rise, which seems to have plateaued around 2015. In Sri Lanka in 2021, thyroid cancer is the second most common type of cancer diagnosed in females, accounting for about 10%, only second to breast cancer. And in males, it's about 3.2%. While the incidence of thyroid cancer has increased, the mortality from thyroid cancer has increased only by about 1% per year. This and other epidemiological evidence have indicated that this increase is mainly due to low-risk, well-differentiated thyroid cancer. Again, some statistics from Sri Lanka. As we know, a well-differentiated thyroid cancer is a disease of younger patients. In combination, the majority of well-differentiated thyroid cancer patients have a long cancer survivorship. So this highlights the importance of tailoring the treatment to the risk of recurrence, reducing treatment morbidities and healthcare burden. For the interest of time, I'm not going into too much details about the pathological classification. However, the latest classification in 2022, there has been some changes. The encapsulated follicular-derived cancers has been separated more. Even previous editions have identified NIFT-P as a benign entity, and this has been further enforced. But also a new entity has been described, invasive encapsulated follicular variant of papillary carcinoma. This has a prognosis in between NIFT-P and our usual follicular and papillary carcinoma. On the other end of the spectrum, also a new entity has been described as a differentiated high-grade thyroid carcinoma. Though this have more aggressive profile than usual well-differentiated thyroid carcinoma and poorly differentiated and less than poorly differentiated carcinoma. For patients with indeterminate cytology, Bethesda category 3 and 4, diagnostic hemithyroidectomy has been the standard. However, molecular testing platforms have been around for a while. They have improved. We have experience with Afirma, latest version, as well as Thyrosec version 3. These investigations are highly specific. That means there's a very high, over 95% negative predictive value, which make them suitable investigations for patients who want to opt out of diagnostic surgery. However, high cost of these investigations make them out of reach for majority of patients. For example, in Australia, these investigations are not covered by the Medicare benefit system, or MBS. So a patient who wants to have this test have to pay out of pocket about over $2,000. We are good at determining the size of the nodules, and also we are good at cytology. But there are three aspects that help us to further identify these low-risk thyroid cancers. They include multifocality and gross extrathyroidal extension and the lymph node involvement. High-quality ultrasound, whether it's performed by radiologists or clinicians themselves, have very high accuracy of describing and identifying these features. So in the previous ATA guidelines, there was a 3-tier system of risk stratification of recurrence, low, intermediate, and high. But in the latest guidelines, they have suggested a 4-tier system. Low risk malignancy, which is risk of less than 10%. Low to intermediate risk of 10 to 15%. Intermediate risk, 16 to 30%, and high risk, over 30%. So we can clearly now define which group of well-differentiated thyroid cancers are low risk after their initial diagnosis and surgery. For papillary thyroid carcinomas, they are the T1 and T2 tumors, which are unifocal, either clinically or pathologically lymph node negative, or have lymph nodes less than 5 involved, with all of them less than 2 millimeters. They have negative margins. They can have microscopic positive margins, but in the anterior capsule. For invasive encapsulated follicular variant of papillary thyroid carcinoma, follicular carcinoma, and oncocytic carcinoma, by the way, they are not called Hürthle cell carcinomas anymore, oncocytic carcinoma, T1, T2 tumors with minimal invasion of capsule with the absence of vascular invasion, and the other features are the same for papillary thyroid carcinoma. So for these low-risk, well-differentiated thyroid carcinomas, let's talk about surgery. In the past, most of the guidelines have recommended total thyroidectomy over lobectomy. That was based on one study, that was Bill Moria's study, which looked at SEER database, large cancer cohort, and they reported higher increased risk of recurrence and death. However, in that study, these patients were not adjusted for their comorbidities, multifocality, extrathyroidal extension, and also importantly, completeness of surgery. However, since then, subsequent studies have shown no difference in survival in low-risk thyroid cancer, whether they had a lobectomy or total thyroidectomy. So in 2000, this has been recognized in 2015 guidelines, but it has recognized with firm recommendations in 2025. For tumors, less T1 tumors, without gross extrathyroidal extension and without metastasis, they have recommended that they should be treated with thyroid lobectomy. However, things like bilateral cancers may indicate total thyroidectomy. For the rest of it, which is T2 tumors, it is recommended thyroid lobectomy is preferred initial surgical treatment. However, it was allow patient and clinicians to decide on a total thyroidectomy, considering the need of radioactive iodine treatment, enhanced follow-up, and contralateral nodularity and patient preference. So the tone has increased in favor of lobectomy. However, the patients who have lobectomy, if you look at the literature, the completion thyroidectomy rate ranges from 20 to 50%. However, these are mainly due to extrathyroidal extension, multifocality, lymph node positivity, which can be identified preoperatively. So if you look at the series which have identified these factors preoperatively, reoperation rate is around 20%. And also, despite 2015 guidelines, the increased use of lobectomy, there hasn't been a mirror increase in completion thyroidectomy. That means we are selecting these patients more accurately. And those who recur after lobectomy, most of the recurrences do occur in the contralateral hemithyroid. And they can be successfully treated with salvage thyroidectomy. And these patients do not have a worse oncological outcome than patients who had total thyroidectomy upfront. So what are the benefits of lobectomy? Obviously, fewer surgical complications. We know that thyroid cancer surgery have a well-correlated outcome to surgical volume. High volume surgeons have been defined variable between 20 surgeons who do 20 to 50 thyroidectomies a year. Even for high volume surgeons, the complication rate for hemithyroid or lobectomy is lower than total thyroidectomy. And certainly, lobectomy have a low surgical cost. And also, lobectomy preserves the thyroid function. The meta-analysis we published found about 70% of the patients retain their thyroid function. And also, logical to think that lobectomy patients have an improved quality of life. However, it's been proven only in the first 6 months. It appears to be so far that quality of life becomes equal in long term. So there are two options for T1 low-risk other well-differentiated thyroid cancers. One is the active surveillance, which was initially initiated around 1993 in Kuma Hospital, Japan, by Dr. Akira Miyuchi. They have published their long-term outcomes. In their series, 10-year tumor enhancement defined by more than 3 millimeter increase in size was about 5%. At 10 years, the development of nodal metastasis is about 1%. However, progression can be higher for younger patients than older patients. These results have been reproduced in other centers in Japan and in other parts of the world. However, when surgery is compared against active surveillance, there was a significant bias against surgery. The patients who had surgery had worse patient and tumor characteristics. So in 2025 guidelines, active surveillance is recognized as an appropriate management option for patients with T1A thyroid cancer, which is the papillary microcarcinoma. So a patient who is ideal for active surveillance is a patient with unifocal cancer, no extrathyroidal extension, and also either located centrally or in the close to the anterior capsule, versus those tumors who are located posteriorly close to recurrent laryngeal nerve, trachea, and esophagus. And having a high-quality ultrasound service is essential. And those patients who do not have strong family history of thyroid cancer, radiation exposure, and also suggestion of aggressive subtypes. Also, a critical component is the having a compliant patient. And the patients not having excessive fear and anxiety of cancer. So how is it implemented? We published a survey of endocrinologists and surgeons in Australia and New Zealand a couple of years ago. So in this survey, 68 of the clinicians discussed active surveillance as a management option with their cancer patients. But only 48 patients have implemented active surveillance. Perceived barriers for active surveillance reported by clinicians include patient anxiety, cancer fear, loss to follow-up, and poor quality ultrasounds. Interestingly, in that survey, surgeons are more likely to discuss and offer active surveillance than endocrinologists. And also, clinicians who use their own office ultrasound are more likely to discuss and implement active surveillance. The alternative for this group of thyroid cancer patients to active surveillance is the ablative therapy. The most commonly used therapy is radiofrequency ablation, and other modalities have also been used. The goal is to achieve a full thermal ablation zone that encompasses the full volume of the thyroid cancer with about 2 millimeter margin of surrounding normal thyroid tissue. So ablation literature comes from very enthusiastic groups, particularly from Asia. And meta-analysis of these reports with over 5-year follow-up has reported very high success rate. However, longer-term results are currently awaited. And complications rate seems to be quite low. So ATA guidelines have got similar recommendation for ablative therapy as that for active surveillance. So, for example, in Australia currently, ablative therapy is not used in thyroid cancer. It is in the learning phase of ablation therapy for benign nodules. The next radioactive iodine treatment in low-risk well-differentiated thyroid cancer. So aims of radioactive treatment are remnant ablation, and the need of that can be minimized with more complete surgical resection. The second indication is as an adjuvant therapy to reduce the risk of recurrence. For low-risk, well-differentiated thyroid cancer, radioactive iodine treatment does not influence disease-free survival and disease-specific survival. This has been shown in a number of studies. Also, this group of thyroid cancer, low-activity radioactive iodine treatment, 1.1 gigabecquerels, had the same recurrence rate as for high activity radioactive treatment confirmed in one randomized trial. So current ATA guidelines recommend for low-risk well-differentiated thyroid cancer, no recommendation for adjuvant radiotherapy, but it may be used for remnant ablation for incomplete surgery. And also for intermediate low and intermediate high, they have recommended to consider radioactive iodine treatment as an adjuvant treatment. And also there's a role for remnant ablation. I want to discuss about the concept of dynamic risk stratification. This was introduced in the 2015 guidelines because the cancer recurrence risk is not static, but it's dynamic. So it introduced the second assessment point 6 to 12 months after the initial treatment. And there are 4 categories: excellence response, intermediate response, biological incomplete response, and structural incomplete response. This diagram from the latest guidelines highlights the importance. We know that low-risk group have less than 10% risk of recurrence. So at the assessment, if they had excellent response to initial treatment, which is usually surgery, their risk of recurrence further reduces to less than 2%. And even the patients with low to intermediate and intermediate to high risk recurrence, which they have initially between 10 to 30%, that can be even further reduced to low risk if they had an excellent response to treatment. Even high-risk patients can come to the level that low to intermediate patients were initially. Then we talk about the TSH suppression. There are studies that show that compared to no suppression or high TSH, subnormal or normal TSH suppression reduced the risk in all risk groups. But further improvements were not detected with undetectable or subnormal suppression. And we know that patients looking after the clinicians who look after these patients, the difficulty of maintaining these targets long-term. In this study, over 1,000 patients in real life, 25 medical centers. Even though most patients were able to achieve 80% moderate compliance, only 30% of the patients were in the target intended. 50% of the patients were overtreated, and 20% patients were undertreated. And certainly there are harms of long-term TS suppression in these long-term cancer survivors. We have published a meta-analysis showing increased cardiac risk, AF, and stroke. And similar findings have been shown for osteoporosis and fracture rate. Therefore, ATA 2025 recommend long-term TSH suppression is not suggested for patients with low to intermediate risk disease who have no evidence of biochemical or structural recurrence in the dynamic risk stratification. That means excellent response. And also it highlights the importance of re-evaluating need of TSH suppression in the other patients in their cancer journey. What about follow-up? So ATA guidelines, I think this is the first time they came up with some strong recommendations. For patients who had a hemithyroidectomy or lobectomy, they recommend follow-up once every 1 to 3 years for 5 to 8 years. And those patients who had a total thyroidectomy but no radioactive iodine treatment, but had an excellent response defined by unstimulated serum thyroglobulin of less than 2.5 nanograms per ml and undetectable antithyroglobulin antibody, similar follow-up has been recommended. For those patients who had a total thyroidectomy and radioactive iodine treatment and an excellent response, and also with undetectable unstimulated serum thyroglobulin and undetectable antithyroglobulin antibody, similar follow-up has been recommended. I think this from, if I'm correct, this is the first time, because our thoughts were that these patients need to be followed up for long time, lifelong. Probably is not necessary in this group of patients who are initially low risk or became low risk after dynamic stratification. So in summary, the majority of the global increased thyroid cancer burden is due to low risk, well-differentiated thyroid cancer. And advances in understanding of pathogenesis in molecular levels and integration of that to the pathological classification as highlighted in WHO 2022 has helped to risk stratify these patients better. And these low-risk, well-differentiated thyroid cancer patients can be identified preoperatively. Surgery can be safely de-escalated in these patients to a lobectomy with active surveillance and ablative therapy in some selected T1A patients give alternatives to surgery. However, such management needs to be done with multidisciplinary setting, with proper, solid, robust follow-up protocols and etc. Radioactive iodine can be omitted in low-risk, well-differentiated thyroid cancer patients with complete resection. And also TSH suppression can be omitted in patients who have a good response to initial therapy. And surgery and extended follow-up can be rationalized and abbreviate safely in low well-differentiated thyroid cancer patients with good response to initial therapy. And finally, the decision to de-escalate therapy and follow-up should be a multidisciplinary shared decision between clinicians and the patients. And those decisions need to be taken considering the resource, cost, healthcare priorities which are unique to each individual clinical setting. Thank you very much.
Yeah. Thank you very much, Professor Edirimanne, for updating us on latest management guidelines on management of thyroid cancer. We will have the questions at the end. I'm quite sure there will be a lot of questions from the audience. So next, I would like to invite Dr. Noel Somasundaram, who's going to speak on update on thyrotoxicosis. I don't think Dr. Somasundaram requires any introduction, so I kindly invite sir to speak on update on thyrotoxicosis.
Thank you, Chairman, sir. Thank you, Prasad, and the CCP for having invited me to speak. What I wanted to do is to give you a broad outline of this old topic. Thyrotoxicosis is well known. It's a classic disease that we see from medical student days. There are modern challenges because of various factors, as I will outline. Commonly, in the 40 years ago, we would characteristically see thyrotoxicosis in emergency ward, having had CVA because of a thromboembolic event resulting from atrial fibrillation and probably heart failure as well. We hardly see that presentation now, but we often worry about cardiovascular risk and atrial fibrillation in the patients who have subclinical thyrotoxicosis. Still patients present with atrial fibrillation, but it's becoming pretty rare. The other thing that we worry about is pregnancy. Can these patients with thyrotoxicosis go through pregnancy? How to manage them? And I will also talk a little bit about diagnostic conundrums and how we avoid mismanagement in patients. Normally, thyrotoxicosis is easy to diagnose because all you need to do is to do a TSH as a screening test, and then if it's abnormal, if it's low, you would go on to do a full thyroid profile, which includes a T4 and, if possible, T3. It's pretty simple. What I want to do in my first section is to outline and show you 6 variants of this scenario and ask whether we diagnose them correctly. So in all of these slides, you will see that on your right bottom corner, the normal levels being listed. But so the first is a young woman, characteristic features of thyrotoxicosis, reasonably long duration, 8 months duration. And she has what we call the classical picture of thyrotoxicosis. She has suppressed TSH, so the feedback loop is working, and that's because her thyroid is producing excessive T4 and T3. Another clue that we use is to ask, if you do a T3, is to ask whether both T4 and T3 are coming out, because sometimes when only the T4 is high and the T3 is disproportionately normal, that could just mean an assay interference rather than a high T3. But this is a patient with classical symptoms. All of the feedback loops are working fine, as you can see. She's got hyperthyroxidemia, both T4 and T3 are high, and she's got accordingly suppressed TSH. Nothing more need to be done other than to ask the question, is it a diffuse goiter? Is it a multinodular goiter? Commonly presentation is in older adults like that, older adults as in elderly people, where it tends to be a multinodular goiter that has now become toxic, and the management is different. There are modern tests and old tests that we used to do. In the olden days, you would do an uptake scan, usually with technetium or iodine, to see whether it's a uniform diffuse uptake, which is no longer necessary because our modern ultrasounds and Doppler studies do give you that information, that it's a diffuse goiter with increased vascularity, which is as good as a high uptake scan in the technetium. What is sometimes misleading to clinicians is the word thyroiditis written in the scan, but if the vascularity is high, it's equivalent to a high technetium uptake. So we take it as Graves' disease in most of these patients. So they are managed characteristically as Graves. The other common test that is used, particularly in resource-rich settings, is the thyroid receptor antibody test. In a patient like this, you will have hardly any information other than prognostic information, as I will show you. So I don't generally do TRAB in a patient like this, characteristic presentation. There are a few scenarios. There are actually only 4 indications for TRAB in general clinical practice, and we will talk about them as we go along. So going on to the second low TSH scenario is a young woman, similar age, who has classical symptoms of thyrotoxicosis, but this time a shorter duration of illness. Now, in this scenario, you can do a technetium uptake, or you can also take a proper history from the patient about the duration. And an additional differential diagnosis is Hashimotoxicosis, where the patient has an acute phase of Hashimoto's thyroiditis, where there is destruction of the gland and release of the thyroxine, both T4 and T3, and appropriately she has low TSH. And if you do a technetium uptake, it will be low. The antibodies are usually very high, but not necessarily in all the patients. And if you do a Doppler scan of the thyroid, it will show low uptake, which is equivalent, as I said, in good settings to a technetium scan. So this could be either Graves or Hashimotoxicosis, and this is where you would value a TRAB antibody test. You can do a technetium or a scan with Doppler to study the vascularity. Third patient is a patient who has features of thyrotoxicosis for about 1 month. Some of them present with fever, some of them just with a tender thyroid. She has features of thyrotoxicosis, and when you do the thyroid functions, she has the classical features of the hyperthyroxinemia and low TSH. What is the diagnosis? This is an inflammation, a post-viral, usually, of what we call the subacute thyroiditis, and the patients usually respond so they will have low uptake, they will have no antibodies because it's a post-viral. They have inflammatory markers though, ESR or CRP will be high. I've seen few patients who have been investigated for 6 months for PUO, and the only test we had found was that ultimately that it was just subacute thyroiditis that had presented as PUO. They respond very well to NSAIDs. They also respond dramatically to steroids, usually a short course. Few patients require a longer course. My fourth patient is a pregnant woman in her early pregnancy who has hyperemesis gravidarum and has been detected to have low TSH and high T4 and high T3. So if you remember your physiology and biochemistry days, you will remember that both the HCG and TSH receptor have similarities. So if the particularly patients in early pregnancy or those with hyperemesis, the high levels of HCG can stimulate your TSH receptor and give you this picture, and they have feedback loop which works to suppress the TSH. So it can be a diagnostic problem because in early pregnancy you have loss of weight in hyperemesis, you have tachycardia, high flushed patient, so they are hyperdynamic. If you palpate their thyroid, you might see that hyperdynamicity. So there is nothing much that distinguishes. So you can do a TRAB in this scenario, which will help you. If the TRAB is positive, she has Graves. You can't do a technetium in a pregnant woman, so you can do an ultrasound to study the vascularity, which is difficult. So commonly, what we do is to symptom control and watch this scenario. Once hyperemesis is controlled, the HCG levels go down, and then the patient settles, and then it will become apparent. So if the TRAB is positive, we would treat these patients. The fifth scenario is a young woman. She's otherwise perfect. She has had a routine screen of TSH, which is low. And then subsequently, you see that her T4 and T3 are normal. What is the diagnosis here? Well, if it's an older woman with a nodule or a thyroid enlargement, then it could be subclinical thyrotoxicosis. But in a young woman who is otherwise well, it usually is an assay interference, as I will show you. So there are particular drugs that can interfere with your assay. Amiodarone doesn't do an assay interference, but has 40% volume of iodine in it. So 40% of that iodine will interfere with thyroid and cause either thyrotoxicosis or thyroiditis, so patients can present with either way. Biotin is a relatively large molecule, which is commonly found in vitamins. Usually people take it for their hair health and whatnot, and that can displace the assay. It's not a problem with the patient, but when you do the assay, these large molecules do displace the binder, and you can't, the assay can't read the TSH, so you get a low TSH. It's not the patient's problem, it's the biotin that interferes. So if you repeat the test, having stopped the biotin, usually 1 day is enough. I usually stop it for 3 to 4 days. And then if you repeat the test, then you avoid the pitfall. We've discussed the other two pitfalls of how you can think of hashitoxicosis and subacute thyroiditis. So when you have a problem in the assay, and when do we think about an assay interference is when things don't fit, when feedback loop doesn't seem to work. The patient is not toxic, but TSH suggests so. In those cases, we can do the test with another assay or stop the interfering molecule and repeat that. Another lab puzzle where the feedback loop doesn't work is a thyrotoxic patient where the TSH is not suppressed. It's either normal or slightly high. In such a patient, you need to investigate for a TSH-producing pituitary tumor, an alpha subunit, an MRI, family history, TRH stimulation test, etc. will tell us what's going on. Ladies and gentlemen, those are the low TSH scenarios that are commonly caught out. And the final one is a patient who is not toxic at all, actually feels unwell, actually has symptoms of hypothyroidism, has lost weight, feels poorly, her blood pressures are lowish, and her TSH is low. And when you measure her other thyroxines, you see that she has hypothyroxinemia. Her T4 is low, T3s are low. She's 65 years old. So when you do her gonadotrophins, the LH and FSH, you might think they are normal, but actually remember she's postmenopausal, so she will by this age have about 50 or 60 gonadotrophin levels. So 8 and 7 means they are low. Her 9 AM cortisol is low. You don't need to do much more stimulation when the cortisol is so low. Her IGF is low. And the diagnosis here is that, as the symptoms have suggested, she actually has hypopituitarism. So despite the low TSH, we know that this is a central problem. So when do we check for other problems and think about other diagnoses is when labs and clinical features are not matching together. In those scenarios, we think about biotin, we think about repeating the lab in another lab using a different assay, and then you also do other tests like the thyroid scan will help in most of the patients, and ultrasound will help certainly in most patients. TRAB will help in few scenarios when there is a pregnant woman with thyrotoxic symptoms, when it's a short duration of illness, and also to prognosticate. If the patient has thyrotoxicosis and has high TRAB levels, then she's unlikely to go into remission early. Coming to the management of hyperthyroidism, we have 3 pillars of management. One is we want to symptom control. Mostly we use antithyroid drugs, and we also think about definitive therapy. And we want all the patients to have a personalized therapy method. So one of the ways in which we use symptom control is by immediately blocking the beta receptors by using beta blockers. Most of the top 3 options, the propranolol, metoprolol, atenolol, they are equally effective, except that propranolol is short acting and atenolol is longer acting. Esmolol intravenous is used in thyroid storm and as an emergency setting to be able to control the symptoms rapidly. For rapid control of severe thyrotoxicosis, we can also use iodine therapy like Lugol's iodine or potassium iodide when the patient has severe thyroxinemia and is agitated or is in impending thyroid storm or in actual storm. We can use Lugol's to overwhelm the thyroid so that the T4, T3 production stops. It's called a Wolff-Chaikoff effect, and you can make use of it for about 5 to 7 days. If you keep giving iodine, patients will start producing more, so only can be used for a short thing. And the surgeons commonly use it as a preparation for surgery. When the patient has a very vascular large nodule, you can bring the thyroid size down by calming it down with iodine. So the treatment, we have 3 options. We have antithyroid drugs, Common drugs are the ones that are still available, but the new immunomodulator drugs seem to be able to function as anti-thyroid drugs as well. So maybe perhaps there'll be newer treatments in the future. Burning off the thyroid with radioactive iodine is another option. And of course, removal of thyroid gives you a definitive treatment as well. So most of the modern guidelines look like that. So you have a patient who is counseled on the various options based on where they are in their life. Do they have a diffuse goiter? Is this Graves? Is it a toxic multinodular goiter? How large is this goiter? Is it a woman or a male? What's the TRAB level? All of those will determine how long this illness will last. For example, a toxic multinodular goiter will never go into remission, and you might recommend a definitive therapy like iodine therapy or surgery based on the size pretty early on in the illness. For standard patients, a young woman with moderate to severe disease, antithyroid drugs are a proper medication. And as you can see, as you go on treating, if the TRAB levels fall, then the prognosis is good. If the TRAB remains elevated, the patient is unlikely to go into remission. So the standard guidelines say treat for 18 to 24 months, check the antibodies. If the antibodies are negative, then you can stop the drug. Otherwise, you need to talk again about a definitive therapy. In our setting, TRAB is not usually available, and most of the endocrinologists currently don't just stop the drug abruptly, but keep cutting down the dose till you come to a very low dose requiring status, at which stage you talk about remission versus long-term therapy. In Europe, when they did a survey among patients and physicians, this was published in European Journal of Endocrinology, as you can see, the physicians and the patients both preferred antithyroid drugs as their primary modality of treatment. Although guidelines recommend radioactive iodine as the preferred therapy, and it's the commonest treatment in US, for example, where iodine is sometimes given as the first-line agent, even sometimes at diagnosis based on patient prognosis. Where I worked in UK, because we also had a physicist, straight away, most patients would undergo radioactive iodine on the day one. In some centers in India where radioiodine is available, radioiodine is the preferred therapy. But what we recommend may not be patient's choice, because as even in the European setting, you can see that patients actually prefer either long-term antithyroid or surgery, despite the guidelines suggesting other ways. So antithyroid drugs, a few words about them. They are the first-line agents. Methimazole is slightly more powerful than carbimazole. Carbimazole is what we use here in first trimester of pregnancy because of the potential for aplasia cutis in the fetus. We use PTU for first trimester and then switch back to either methimazole or carbimazole. Because PTU is associated with hepatitis, we don't use it on a long term. So as I said, on a patient who chooses antithyroid drugs, these are the types of patients who can be counseled to be on antithyroid drugs and perhaps go on a long-term treatment with that. If the patient gets controlled easily, if the thyrotoxicosis is not severe at the onset. As I said, the levels of thyroid function also determine the prognosis, smaller goiter and lower TRAB at the beginning. Whereas those who are unlikely to achieve a remission even after 24 months are those with a high TRAB at the beginning, those who continue to smoke, those who have a large goiter, and as I said, that multinodular goiter will never go into remission. Postpartum is associated with poorer prognosis, as in they won't go into remission, and higher dose requiring. Male gender is associated with longer disease duration as well. There are a few side effects of antithyroid drugs, as you know. Skin rash is common. Arthralgia is common, usually responds to a small dose of NSAIDs or paracetamol. Very rarely you can have ANCA positive or just a vasculitis in patients, very rarely. Most of our patients will have some leukopenia, but agranulocytosis is rare but reversible, but something that you need to look for and counsel patients on. Carbimazole and methimazole cause cholestatic jaundice, whereas PTU is more likely to cause hepatocellular damage. So these are the common, or these are the side effects. Most of the severe ones are pretty rare. And despite most guidelines saying at 24 months, stop ATD because they are toxic, move on to a definitive treatment counseling, you saw how in our practice, most patients don't want a definitive therapy. They would like long-term antithyroid drugs. Sajid, when he was SR endocrinology, we analyzed our patients there were about 380 patients on long-term antithyroid drugs and wrote the safety data of that. This is a paper recently published, as you can see, that had looked at treating patients for 5 to 10 years with antithyroid drugs. And then at the end, they show that on the ones on the unbroken line, those on long-term therapy actually had lower remission rate as opposed to if you stop them at 2 years as the guidelines say. So and they also showed that the side effects were very minimal. There were skin reactions in about 4% and marginally raised ALTs in about less than 1%. So what most people now figure out is, although guidelines tell us to stop and move patients to a definitive therapy, most patients can tolerate antithyroid drugs effectively. And agranulocytosis and the cholestatic jaundice, which are the dreaded complications, occur within the first 3 months because they are idiosyncratic reactions than a dose-related complication. Radioactive iodine is what we would usually use, and of course, surgery is a good therapy. So, in the era of these triple options, how would you choose patients? It's an individualized decision, as you can see. Antithyroid drugs are not permanent, and they don't offer recurrence-free therapy, whereas these two other therapies offer you permanence of cure. In orbitopathy, you cannot use iodine, so you will use either one or the other. In pregnancy, you will use radioiodine. In pregnancy, you wouldn't use radioiodine, so you would, in a patient who is planning pregnancy, ideally use antithyroid drugs unless there is more than 6 months left to plan for pregnancy. Otherwise, all three options are equally effective, and adverse events, even with surgery, are pretty low. So patients have to be counseled accordingly. So this is the way a personalization matrix would work. For a newly diagnosed patient, ATD is the primary treatment, and then the others, if they have a recurrence, a permanent therapy like radioiodine would be the best. For pregnancy, antithyroids in first trimester PTU. For breastfeeding, antithyroid drugs, although they are somewhat secreted in the breast milk. If there is suspicion of cancer or poor prognosis, as in multinodular goiter, etc., thyroidectomy. If there are major adverse events due to antithyroid drugs, you will definitely move to radioiodine or thyroidectomy. And if there is Graves' disease and associated with ophthalmopathy, either antithyroid drugs or thyroidectomy. But if you are using radioiodine with steroid cover for moderate ophthalmopathy is possible. In the interest of time, let me thank you all for attentive listening and thank the CCP for having invited me to speak. Thank you.
Thank you very much, sir, for your excellent lecture. So this symposium is followed by 15 minutes of panel discussion. So may we kindly invite Professor Senarath Edirimanne and Dr. Noel Somasundaram on stage. And May I kindly invite our expert panelist, Dr. Maheshi Amarawardhana, consultant endocrinologist, District Hospital, Chilab. So the ladies and gentlemen, the forum is open for discussion. If you have any questions, it's your time to ask.
Actually, Dr. Edirimanne, thank you for enlightening on that topic. Actually, what we had seen is perhaps over-treatment of quite, well differentiated, low risk thyroid cancers and microcarcinomas. And so I think it's not really a question, and enlightening us, and so that more people will resort to this sort of conservative management. Where we have seen, actually, I have seen a patient dying where we could not manage hypocalcemia even with protracted IV calcium gluconate and then PTH injections and everything. So this is very important. Thank you for your, and any views from our colleagues.
Can I ask a question from Prof. Edirimanne? Now, you spoke about conservative management or less aggressive management of thyroid cancer. One of the biggest problems that we encounter is overdiagnosis. Somebody goes and gets a screening ultrasound of the neck done, they detect a few millimeter sized nodule, and then FNA is done, and then they come with a diagnosis of cancer. So once you label somebody as having a cancer, from that point onwards, management becomes extremely difficult. So I know 2025 ATA guideline doesn't talk much about diagnosis part, although it was there in 2015. What is your management when it comes to screening ultrasound or FNAing of tiny ultrasound detected nodules?
Yeah, it's the same problem is there as well. When a patient gets referred to us, they came with ultrasound biopsy results, these microcarcinomas. And Australia is a very multicultural country. People come with different backgrounds, and the word cancer means some of them needed the surgery yesterday. That's the approach they come up with. So first of all, you have to have, it's a shared decision with the patient and you. So we discuss the low risk. The uptake of active surveillance is still low. And even in those large series, the major reason for those patients to have surgery is those who selected active surveillance, they change soon, because of this idea of living, not treating cancer is not acceptable for a lot of patients. So I would say in my practice, so I discuss active surveillance as an option with all my patients, but probably only 5% will accept that. And then doing surgery to the risk is certainly lobectomy has been much more accepted in our patient population.
I'm hoping that the nodule prevalence will go down in future, because if you look at the continued national survey of, or at least the 2 surveys that have been done, you remember the nationalization of the iodization program occurred about 25 to 30 years ago, and then the antibody levels went up in the population, and as a result, the nodules. So if you look at the past surveys, even in school children, the nodule prevalence was about 8 to 10%. And so those are the women who are now coming with these investigated thyroids, which are having multinodular goiters and multiple nodules. And that's where we find something micro and then get excited. The recent surveys show that the antibody prevalence has gone down, and the nodule prevalence is now about 3%, as opposed to close to 10% like 15 years ago. So hopefully the next generation will have less nodule prevalence, at least from the limited data we see. And that might actually lower the, overall, the low risk cancers as well.
I think the other problem is like Professor Katalanda's autopsy study had shown, about 10% anyway do have a tiny papillary thyroid cancer. So when we start utilizing or indiscriminate usage of these screening ultrasounds, we are going to detect these tiny nodules. I think one thing we need to be very cautious is putting a needle, because ATA clearly mentions unless it's highly suspicious, still 1 centimeter should be the cutoff, unless of course the patient has other risk factors. But here we see a total different picture. The radiologist himself or herself will decide to put a needle in, then the patient will end up with an operation. So that is something we can probably work on. Whether the same, do you all have any protocols, anything in Australia to prevent these unnecessary fine needle aspirations?
Yeah, the protocols are very similar to 2015. Said that you should biopsy, unless there's other reasons, a nodule more than a centimeter. But, patients come with biopsy by the time they come to you, because radiology practice is not standardized, and the GPs send the patient and the radiologists recommend biopsy, and they come up with the biopsy results. They still have the same problem.
Maheshi has got, yeah. In our context, most of the patients are very anxious, even having a slight, even not having a thyroid nodule sometimes. So, I mean, in our setup, can you just suggest when to do the first ultrasound scan? So I think that's where we ended up having detected
Sorry, so you're referring to the patient with symptoms? Yeah, so most of the incidental nodules we see are done for very non-specific symptoms. Patient go to the GP and say that I've got an ache in the neck, and the GP refer the patient to an ultrasound scan, or they have a carotid ultrasound, they find thyroid nodules and so on. So I don't think there's a routine, unless you have a very strong family history of thyroid cancer, to do a routine ultrasound of the neck, unless there's a clinical concern.
My view perhaps would be that, we have to get the radiology colleagues, into this, use the thyroid scoring on performing the needle testing. What do you think that Senarath?
Yeah, so it has taken a long time in Australia also to radiologists do the thyroid scoring. So now all the ultrasound reports comes with what's the thyroid score, what's the indication for biopsy. But having said that, if they look suspicious, they still most likely do a biopsy. But the TRAD 3s and 4s, they tend to recommend. But the difficulty is, sometimes patients comes with the multinodular goiter saying right side follow-up 6 months, left side follow-up 12 months, so nodules, and which is not practicable. Sometimes we do biopsy to triage our management, so it's not possible to do ultrasound 6 monthly on one side and 12 months on the other side.
I think we must thank the first speaker for highlighting the importance of the higher prevalence of primary hyperaldosteronism than we thought of. In our setup, I think it's a completely neglected area where even young hypertension, I don't think that the clinician has intention of investigating. So I think even in the absence of hypokalemia, as we saw, I think always we as clinicians, we have a responsibility of starting investigating, particularly for primary hyperaldosteronism. So that's all.
Okay, in the absence of further questions, I would like to conclude this session, Symposium 20 on Adrenal and Thyroid. I would like to thank the speakers, Dr. Ricardo Correa, Professor Senarath Edirimanne, and Dr. Noel Somasundaram. And I would like to give the certificates to the speakers. Professor Senarath Edirimanne. And Dr. Noel Somasundaram.
Could I now please invite Vidya Jyoti, Professor Prasad Khatalande, to award the certificates and letters of appreciation to our chairperson. Ladies and gentlemen, with that, we conclude Symposium 20. We'll now pause for lunch.
We need to give one to Dr. Maheshi. Panelists. Sorry.